Yeah. Oh, there we go. Perfect. Yeah. Okay. So fantastic. As always. And are you going to have? Are you going to wear this radio mic, or do you want this one? Yeah. Great. Thank you.
Thank you for this nice introduction. Dear colleagues, good morning. I come from Varna, Medical University of Varna. Thank you, Robert, for this invitation. As always, I learned too much for 2 days. For 2 wonderful days. And my topic since 1999 is biomaterials. You know, the biomaterials is very important for physicians, for any specialty, not only for ENT doctors. The biomaterials used for reconstruction of ossicular chain must present a good degree of biocompatibility and biostability. The most become osteointegrated with minimal risk of ankylosis. Severe questions are of paramount interest in solving this problem. Biomaterials selection for ossicular prosthesis construction, design of ossicular prosthesis. This is very important validation of biomaterials, monitoring of patient with implanted ossicular prosthesis, and contemporary design of ossicular implant, selecting biomaterials. Selection of biomaterials, what to think about these biomaterials? I invite 2 scientific group, and in the end they decide this material, it was suitable for the great pétanque in France. So, one point of my presentation, I briefly showed the validation of new biomaterials, use it as well as modern ossicular prosthesis in experimental animal models. This is an important step of development of ossiculoplastic. Examination of biomaterial properties from which the prosthesis is fabricated, mechanical and biomechanical characteristic, this proving the absence of material toxicity, and implantation of the biomaterial itself and as a prosthesis in experimental animals. The contemporary criteria for the selection of ideal materials, specifically was the ideal implantable prosthesis produced from them are very damaged, but never not been met yet. Is there any ideal biomaterials? In this time, I think it's not available. Initially, the new materials were placed in the patient bodies to the test whether or not they showed biocompatibility. Nowadays, of course, such methods are not used. We should first perform in vitro tests, most often of cell cultures. In vivo animal tests follow next, and then after too much time, clinical trials are performed on patients. The biomaterials must be tested for cytotoxicity, sensitivity, irritation, of course, genotoxicity. I find too many articles about biomaterials, especially for middle ear prosthesis. It is important to properly select the biomaterials in the specific clinical case. Biological tissue, metals and their alloys, polymers and composites, ceramics and carbons. Since 1999, we have experimental protocol for gold, titanium, platinum, titanium, among plastic materials, polyethylene, Teflon, plastipore, and glass ionomer, cement, glass ceramics, bioverit, McCord, and another brand of biomaterials. The body response is much important. It's not universal and depends of 2 factors: the nature of the implantable biomaterials and the individual answer of the host. Another good study about the biomaterials. Different ceramics such as aluminum oxide, glass ceramics, most of them are already absorbed. The hydroxyapatite is very interesting ceramic system. We are happy that nowadays we use the prosthesis of this material. This is our laboratory of histomorphometry of the car section of materialograph in our dental faculty and medical university of Varna. Laboratory incubator, laboratory freeze dryer, and precious cutting device. Of course, this is our old results of Teflon materials. Another good study about this is scanning production of our prosthesis in Guinea-pig models and same torp and pore prosthesis. We stopped with this material. The last prosthesis we produced 2008. Advantages of the Guinea-pig models. This is too much. I don't speak about this. And this is for the last week. We received the new microscope, and we was together with our colleagues of dental faculty. This is our protocol for target vector system many years ago. No toxicity of this material. The response was wonderful in the recipients, and the good acoustic system with this prosthesis. Can I show our experience between 1999 and 2008? This is a result after investigation test for Teflon target system. I like this picture too much because this is into the historical aspect, different materials the last 60 years. Nowadays, we use different biomaterials. Maybe the leader is titanium. You know, we have different titanium alloys, around 500 types of alloys. Another Teflon piston prosthesis. I repeat that it's very good to use the Teflon system, titanium and hydroxyl apatite. We start to find another material for the future, but it's not so easy. And in the conclusion, fabrication from a suitable biomaterials characterized by good acoustic properties. Design is very important. It is very important to feel the surgeon feel comfortable, and in the selection and quality of biomaterials used for reconstruction of the auditory ossicles. In both the prosthesis design and the operative technique is important. Monitoring of patient with implanted ossicular graft or prosthesis is very important process. This is my reference for this time. See you again in Béziers, I hope. And thank you again for this wonderful 2 days for my colleagues and of course the team of Robert. Thank you so much. I invite the next presenter. I continue to biomaterials.
Thank you very much, Mario. I'm going to present, so just hold on.
So you met, I don't know if you've met this guy. He's a magician. Did you? I don't know how many people were there last night, but he is. I mean, he's a real magician, isn't he? It's extraordinary. And Dwayne does his ear surgery without actually having a microscope at all. He just puts the prosthesis in with a clip, don't you? I mean, amazing. So, you know, occasionally he's not allowed to do his magic, and he actually has to go to his day job. And he is a real magician. He's a magician who's actually made his own hospital in Johannesburg. He's got an eye and ear hospital, which is absolutely fantastic new build hospital. It's the sort of thing you would dream of having. It's quite remarkable. So he owns the hospital, runs the whole thing, and has got a very big otology practice in Johannesburg, cochlear implants. But the clinic is, if you ever go to Johannesburg, you should go and visit. It is absolutely stunning. It's like a dream hospital. So it's a huge pleasure to have you. And are you talking about cement?
Yeah.
And he does remarkable things with the cement. But I do sometimes wonder why he bothers with the anaesthetic and the microscope and doesn't just click the fingers.
Thanks so much. Something, you know, like everything in life, I just want to see that it, all of a sudden the presentation was working and now is not. The slides are not downloading. We're now? Shucks. We'll have to do a trick. Okay, I want you to think of a card. This is not downloading. Okay. Oh, yeah, that one. Okay. Perfect. Let's hope the videos work now. So for something completely different. We've watched incredible surgeries. We've listened to excellent talks, and I thought one thing that I've really come to know or come to use in South Africa was the cements. And I know they fell out of popularity, and I saw in Mario's talk as well, a lot of people have sort of abandoned them. And the reason was, and I actually went to go and speak to the manufacturer of the cement we use to try and get them to manufacture a product that we could use directly in the middle ear for the middle ear. And they said, you know, Dwayne, the whole of South Africa uses this amount of cement. A dentist uses that amount in 2 weeks. So the amount of cement we use for the ossiculoplasties is the same as what a dentist will use for caps in 2 weeks. You know, it's just not even worth them actually investing further in this. And to get FDA approval and to get CE mark, it's an expensive exercise. So what happened is, in my journey in 2006, I started experimenting with cement. And in 2009, I sort of came across this cement and found this was the one that worked the best for us, had the best properties, and I'll explain now why. The problem is, it's not expensive, it's cheap, so it works well for the South African market. And what we have here is, let's see if the pointer will come up. You've got the little spoon at the bottom here, and so these are products that are off the table. This is then sterile, just the lid with the handle, and the spoon is sterilely packed, and then that is gas sterilized, and then I get given that on my tray. I then take the spoon, the sister just holds this, and I will scoop a little bit of cement, and then the dropper is turned around. I screw that on and just drop 2 drops on. Anyway, we can talk about that later, but I just wanted to put a disclaimer that I don't have any company benefit from this product, but this is the one that worked for us. It's called KetaChem. Really good product. It basically consists of the powder, and you can see polycarboxylic acid, as well as the liquid, which has got a tartaric acid in and a conservative agent, and that bonds the two. You've got about 35 seconds to mix it. You've got a working time of about 2.5 minutes to 3 minutes, and it's fully set at 6 minutes. So really hard at 7 minutes. So you say, ooh, that's a bit fast. So the nice thing is we can remix during the case. So we often remix 3 or 4 times, make a new little set each time. So the guys in Europe said, Dwayne, we need this to be sterile. So I was very excited when they brought this out. It's a once-off use. You need to get all these applicators. You also need a centrifuge in theatre, which is not really practical. But the problem here is the consistency of the cement that comes out is a little bit too much like putty. And we want sort of a wet toothpaste kind of consistency to be able to work with the ossicles. And you'll see now in some of the videos. So this is something that I could never understand. We would never build a bridge like this. You know, you don't just pour the cement on the edge and just hope this thing's going to stick on. So, I mean, just think of this as the Incas, all right? You can't just put cement on there. my cousin is a builder, and we were laughing the one day, and he said, "Well, why don't you guys use?" This was many years ago. Why don't you use what we use in the building industry? Put a cement core in your, put a cement core, concrete, a steel core in your cement when you, it just increases the strength." And that made a lot of sense. So I went back and I started working on this. And so what we now have done, and we've presented for many years on this, you're welcome to go back and look. I'm not going to go through all the basics. We're going to go into some new applications today. But the idea is that we place a 4-0 nylon. Initially, I started with a 2-0 nylon, and you just take the nylon that you've got in theatre, you just cut it, make sure it's a non-absorbable suture, you just cut it, and you sort of guess what, eyeball the right size. So I cut a whole lot of little pieces, and then I'll mix and match until I get the right size. You place it across. That's a typical incus-pedal joint disassociation. You then put some cement on it, and there you go. And I thought what we'll do here is just show you what that looks like in real life. No, not like that. So this is a patient with a history of, she'd have, I think it was just a chronic ear disease over many years, and she sort of had this hearing loss for a number of years. And you can see a very mobile stapes. I'm going to fast forward a little bit. I'll just leave it, it'll come up now. So you can see we've actually got a pretty much hypermobile stapes there. So one's very reluctant to go and put a PORP on top of that. It's a good idea, and a Dresden clip will work very well there. So what we do here is we put a little bit of cement on top of the head of the stapes. We put a little bit of cement onto the edge of the incus. So that would be sort of, I've just mixed it, and you can see the consistency. I want you to get an idea of the consistency of the cement. And then we'll place my 4-0 nylon. So this cement is glass ionomer, okay, so it's not hydroxyapatite, and I know that's the one most of us are aware of, and in South Africa that's just too expensive. We really can't afford that, and you can't really remix, you've got to open a new bottle every time. So the idea there is once I've let it dry, so I've let that set a little bit, then I've gone with another mix, put that on again, just give it a little bit more, and then basically what we do is we now use that as our core, because now we can actually direct the cement along that core and put a nice sort of incus looking like structure in within about 5 minutes. This is hard, and 6 minutes it's fully not ossified, fully solidified, and you can then go on with the rest of your presentation, rest of your surgery. So one concept that made me change to cement was the idea of not only stability of the prosthesis, but we also see, if you just never made sense to me, if we put a torp or something, what's attaching it to the foot plate? And we know that there's that bimodal movement of the foot plate that might give you that increased hearing. And if we've just got sort of a prosthesis sticking on that foot plate, when it lifts, are we getting that same amount of benefit? So this was, I don't know if how true this is, and it's I can't give you studies to prove this, but this was just a concept that made me think further. So you say, Dwayne, okay, it's great, you've put this blob of cement in. What's going to happen to that blob of cement? Does it dissolve? And that's where those 3 years in the beginning, we tested it, we unofficially put cement in ears, reconstructed it, and we had to really believe that this works. Now, belief doesn't change the fact that it does or does not, but what I'm saying is we had to prove to ourselves that it worked. And in 2009, I was sufficiently convinced that we have not had any breakdowns, everything was fine, that I could now continue to use it. But it was only in about 2011, 2012 that we started with a nylon technique. And so since we started using the nylon technique, very, very few, in fact, on one hand I can count those that have broken down, that have come loose. So it doesn't dissolve, it never caused sensory neural hearing loss. Has it integrated with the ossicular mucosa? Well, I'm going to show you that in a little while. What is the blood supply? Is the nylon core robust? So there's a couple of questions we wanted to ask. So here I'm going to just quickly show you, and I'm just going to run through this. This was the brief surgery in 2006 of a patient that just needed an incus stapes, sort of typically what we've showed there now. I'm just going to briefly show you that we've seen pretty much the same procedure. We're going to move on to there. You can get the idea. So I put the core in there. You can see the core is in place. I'm just slowly building that up. That's pretty much what it looks like towards the end of the procedure. Okay? It doesn't stick to the quarter, believe it or not. You can just lift the quarter up and we have no reaction to the quarter. That was our pre and post at that stage, but look what happened. I had to re-look in this ear 4 years later. This is the exact same ear. Have a look at that blood supply surrounding that cement. It's almost like it's got mucosa that's now vascularized. So that was a very encouraging thing to see. So
why did you go back in?
She's had a lot of vertigo just out of the blue, and there was a positive Tulio sign, and I was a little bit worried that we might be sitting with a fractured foot plate or something. Well, not a fractured foot, but something weird. And so we were looking for a fistula. So we just opened to look for a fistula while we were there. Maybe I was a little bit biased because I wanted to see what was going on, but I had a good reason. So I went in and looked, and fortunately it was okay. We actually didn't find there wasn't a perilymph leak. Here's the original stapes surgery in 2013. This was before, and you can see that we actually have quite a long incus. So we didn't feel that we needed to put the nylon core in here, and I'll explain now what I mean by that. But I had a terrible experience in my early days where I removed a piston that was in the, from the fenestra, and I had incapacitating dizziness in this patient. Eventually, we actually did a labyrinthectomy, and she has no hearing in that ear because it was just so bad. We just couldn't fix it. So I'm scared to take a piston out of the oval window. Now, I know Robert's going to say, Dwayne, use a vein graft, and I don't. I use a fenestra. So I just wanted to show you that's what we did. We then placed a little bit of cement just to keep it in place. So that's pretty much what it looked like in 2013. Let's see what it looks like. So that was the before and after, not worried about that. That's what, I opened it up 10 years later. Sorry, this is the one that was the perilymph fistula. The other one, I can't remember now. Sorry, Chris. This is the one that was the perilymph fistula. I apologize. So you can see that's what it looks like 10 years later. It hasn't changed, hasn't moved, looks great. So it is, not 10 years, this wasn't a cholesteatoma though, so it wasn't an eroded, badly eroded or anything like that. Let's move on to the next slide. Here you can see a similar situation. If you look on the right-hand side, shucks man, I don't have a pointer. If you look on this left-hand side over here you've got a similar case, and you can actually see took maybe a little bit too much of the scutum. We've had a retraction, and it's lying nicely on the ketochem, and it's not reacting to the drum in any negative way. But this is how I now do my revision stapes that have come loose. This is a patient, this is an old video, I apologize for that. So you could say to me, Dwayne, why don't you just put the piston back over the incus there? Because it would fit. But this was just angled in such a way, and it was under too much tension. And so what we do is we place the little nylon strut between the sort of the loop of the piston. We then put a little bit of cement. We then hold it into position, and it's amazing. You hold for 30 seconds, and that thing is sitting. It's 30 to 40 seconds. It's already sitting, but it's only fully healed, fully solid at about, like I said, 5 to 6 minutes. We just put a little bit more on there. Then I moved the piston slightly up. Sorry, for the sake of time, I'm going to move a little bit forward. So we move the piston a little bit closer now to the incus head, the incus long process. And then you just complete it like that. So this patient wakes up totally vertiginous free. There's very little risk. They can fly very soon after this. There's none of that usual stapes problems. And so this is how we do a lot of our revision stapes nowadays, if we've still got, and then you can see a nice ossicle intact chain. So what have we learnt? Well, over 15 years it's robust, and it's managed to stick there. It's able to be enveloped by good blood supply, no erosion. The nylon core system seems to be the stronger and more durable repair. Interestingly enough, we have had some stages where we've had to go back and just laser one, or while I've just put on a little bit too much cement, and there's not enough place for the prosthesis to fit, so I just quickly laser a little bit off. It doesn't cause any damage, no fires or anything like that. Ignore the one about the foot plate. That was an accident where we had a fractured foot plate and there was some cement on the foot plate. I was devastated. I thought we can have a dead ear. It turned out nothing serious. Fortunately, that patient retained all her hearing, but that's a case of one. It's got a similar weight. We did some studies, very similar weight to the ossicles. It doesn't adhere to silicone, so if you are worried about something sticking to the side, you just put a piece of little silicone and it'll keep it away from attaching. So we've just talked about this. This is the same concept. The idea here, we've got quite an eroded, sorry, it's a little bit difficult to see. You've got the piston over here, the incus high up over here, and it's really stuck, and it's a lot of adhesions. I'm a little bit reluctant to pull this out of the fenestra. We basically do what I've just showed you now, go through the loop with the nylon. We're using 4O nylon, as I say, rebuild that. And so far, our longest case of this, our first one that we really did like this was in 2013, 2014. She's my audiologist sister, and she's still fine, hearing well. So that's going well. That was the pre and post-op of that case. So you say to me, well, Dwayne, what about a second revision after stapes surgery? This patient was referred to me. You can see on the right, on your left-hand side, after a stapedotomy done. I did the revision in 2009. This was done in the early 2000s. The piston had actually, exposed and it protruded through the tympanic membrane. Not a good position to be in. That's what we found. Sort of an eroded tip of incus that we basically removed, and now we had to replace the piston. But at that stage, I was sort of, this should be fine for a little bit of cement. So I put a little cement on there, was happy, had a lovely result, and was very chuffed with myself. Didn't even last 2 years, 2.5 years exact. I had to go back. We'll look on the right-hand side now, and that's what I found. Cement around the piston head, and an incus not touching at all. A little bit worried. If you just take the crocodile and you just carefully just clamp onto the cement, it actually just cracks and disintegrates quite easily, and you can then use that piston. I'm going to show you there now. So we just gently just take that. We're able to remove the cement. Now I know you say, well, that's so easy, then surely the cement will break. Well, somehow they stay. I don't know why, but we're having very consistent results still long term. So this, again, we learnt, and we then put in our little nylon core on this patient. Just for sake of time, I'm going to move on. And that patient is now still doing very well. So that was the first one, far left. When I first saw them, that was after the first revision. And then 2 years later, 2.5 years later, she presented with this after a flight. We've repaired that, and that's what we're sitting with now. So that's the third revision. First and two revisions after that for her stapes. But what I like about this is here we've got a congenital small airbone gap, not a massive thing, and I opened up. This is the endoscope view, obviously more accurate view, and there you can see that just no connection to the stapes head. The incus is there. We've got the tendon in place. We'll show it from you from another angle, and a mobile stapes, just a little gap. Now, it's just against my grain to say, Dwayne, let's take that incus out, do an incus into position, or let's do a torp in that situation. And so there you can see the stapes is very mobile, nice round window reflex. So this was a very easy situation. You say, Dwayne, we're just going to put a little bit of cement, but true to my rules now is I almost never use cement without a nylon core. So we just put a little nylon core. It actually stuck, and I just used a bit of its properties to swing it into the right place. Just a small piece, just to cross the defect. Again, what it does is it just tends to bind the cement a little bit better, and then we end up with a result looking something like that. And a very nice overclosure. Well, not overclosure, but a nice closure of the airbone gap. This was not done too long ago. This is about 2.5 years out, so he hasn't had chance. One of the things that is a little bit controversial, but we've been trying is when you get in and you've got a little nubbin on your foot plate of your stapes crura, there's a small bit left. And I sort of thought, well, why don't we use that to build up the little bit of cement on that, and then from that nubbin. So you can see we've got a small nubbin over here of stapes arch, and at this stage, this actually, and you can see it here, is a revision of one of my cases. What happened is I never really attached it well enough to the stapes. So you can see what you're seeing there is actually a ketochem was attached, but it came loose because we hadn't really attached it nicely. So that's a piece of nylon. That's the ketochem, and so we gently just put it on top of that nubbin. We then rest this. Now, please, we're not saying this should be for every case. This is just something different to be controversial, all right? And then on top of that, we glued the, I'm just going to, for sake of time, just move a little bit forward. We put our little new nylon. We continue to just envelop it with the ketochem, and sort of, that was our final look. And the good news is, this is about 4.5 years out, and this patient is still fine. That was our pre and post. So, I'm going to pass on that for time. What happens, Dwayne? The scary thing, you've gone in, you've decided you're going to put some ketochem on your little nubbin of your stapes or something, and the stuff spills on the foot plate. So I'm going to do a real-time surgery here, in the sense that I don't want to edit this, just so you can see exactly what happened. So here we are doing a similar repair where we're using the nubbin of the the posterior cruce of the stapes, and I'm putting a little bit on, and it is quite, and there you see it just sort of tracks down onto the footplate. You know, if you leave that, you're going to get a stuck footplate. The nice thing, you've got about 2 minutes before that sets. So you just go in with a sucker. I've left this to run just so you can see this is genuine time. I'm not panicking, as Prepper says. Don't panic. Just get the sucker. Just get the sucker. And so this was just, we didn't have the right size sucker at the time, so we quickly got a slightly smaller sucker. That's why we're delaying it so much. But I want to just show you, this is just the exact time quickly before we go on to the next. We just, small little. So we've got time. It's already been 38 seconds. And you're easily able to just suck that away. Okay, so that's not too much. So something that we've started doing that really, when you've got a fixed foot plate and you're sitting with an eroded incus, we actually build up and make a new incus by putting a little bit of cement on the body of the incus, putting our nylon to where we would think the incus probably should lie. We can position it wherever nicely over the stapes, and then we slowly build it up, and this takes a little while. Problem now is that I built this up nicely, and on this case, I now need to drill the stapedotomy. Sorry, just for sake of time, we're going to move on. And while drilling the stapedotomy, I fractured it. You see here? The nice thing is, because the nylon core was in place, it's not a problem. It's still fine. We were able to carry on with the surgery. Surgery was then continued, and then we just reinforced it at the end of the surgery, and it's strong and doing well. I'm going to move on to the next one. That was a nice result there. So, this was something totally different, and please, this is different ideas. So I'm not saying this should be for everyone, for the young guys out there. So what happened here is we had a bad cholesteatoma that, well, not a bad, not a massive one, but a cholesteatoma that had eroded a portion of the malleus, the whole long process of the incus, and had the stapes was also fixed. Now this was probably tympanosclerosis, not otosclerosis, obviously. So basically what we went in and did was we separated the, this is what we found. Sorry, this is what we found. I'm going to show you that now. I just want to show you the steps that we did. We then cemented the incus and the malleus together first. We then built our little nylon strut, reinforced our nylon strut to make an incus, then did the stapedotomy. Excuse my little drawing. It's not as good as Saji's, but I try to make a little drawing of the piston and put the piston in and then put the cement on. So this is what you're going to see now. I'm going to just run through that quickly. I don't want to go too over my time here. So basically what we're dealing with there is we've got a slightly partially eroded, just a long process with a little bit eroded of the malleus. You've got the incus, and they're not, unfortunately, connected really. The joint is open. So basically I glued that together with a little bit of cement. Then I extended with the nylon across you can see the facial nerve there. We extended that, built that up. Then went ahead and had a nice movement there. So then I was happy to go and drill on the stapes footplate. Drilled in the stapes footplate. Sorry, man, the one's an endoscopic view, the other's the microscope view. And while I was lasering the piston, it cracked. You'll see now. It suddenly cracked so obviously it was weak, not strong enough in terms of the cement, but it's perfectly in place, and I just reinforced with a little bit more cement afterwards, and that patient's doing fine so far. All right. That was a nice result there as well. This was a embarrassing situation. It was a 25-year-old lady, which I think was a congenital hearing loss. She said, well, she can't really remember ever hearing her, hearing very well in that ear. I did a CT scan, but South Africa, we got limited funds. The medical aid said, no, you can only do coronals. So we only did coronals, and we had quite thin slices, but I could not, and I was looking for a malleus head fixation, could not see it. Wasn't there visible on the slices we had. Subsequently, afterwards, we did go back and we convinced the medical aid we need axial slices as well, and we were able to see very nicely that there was actually indeed. But I was expecting some sort of strange middle ear issue. There wasn't much to see on the CT scan. So what happened is, in theatre, you're going to do a stapes, and now suddenly you find a malleus head fixation. You've gone endorally. There's lots of techniques. Robert will tell us what techniques he's used. This was the technique we used. We just decided to separate with the laser and the drill the malleus head. separated the joint, obviously after separating the joint of the IS, and then just rebuilt there the connection to the malleus and incus, and then I did reinforce the joint. Probably wasn't necessary. So that's just to give you an idea of what we did. This is how it looks. Sorry, again, my microscope, this is a little bit overexposed. Our microscope is getting old. We need cameras. All right, so what we've got there is we've got a mobile stapes, but we've got a fixed malleus. For sake of time, let's just fly through that and just show you basically. So endorally, that's just the neck of the malleus. I'm just lasering that off and then drilling that off. I know there's a lot of char. We then have the incus, which I'm going to bring into position here. Sorry, there's a little bit limited views. You'll see now in a second. There's the incus. We're bringing that together. So there was almost like a little triangle of malleus and a triangle of incus that's sort of just touching. Remember, I have separated the incus joint, so we're not putting any extra tension on that stapes. And then we glued them together there. Again, in true form, we had to do a nylon strut. So that's in there. Little nylon strut across. Glued that together. And then went back. And you'll see then just reinforced the stapes joint. I think that was probably unnecessary, the stapes joint, but just to make sure. And I tried to get hold of her. We have that. I haven't seen her after her 6-month follow-up. It's been a while now. She's lost a little bit to follow-up. But that was 2 weeks post-op. And that was at the 6 months audiogram, but I haven't seen her since. I'm not sure how well it is still going, but I just wanted to mention that to you. So, what are we saying in wrapping up? Currently, with glass ionomer cement, the Ketochem that we use, these are the 3 indications that we now use it for. I do normal stapes, I do normal ossicle prosthesis, I love the Dresden clip, but this, if we're going to use cement, these would be the indications we'd use it for. So, simple closure of the IS joint, great in those cholesteatoma cases. Revision stapes where you don't want to remove that piston. Look, obviously, if the piston's out of the fenestra, it's not a problem. But if the piston is deeply set in that fenestra, I'm really nervous to take that out. So I use that revision stapes with a nylon. And then this is something that we started in 2013, 2014 was the first case with this. And it's gone so well that we continue to use, if we have an eroded incus and a fixed stapes, that indication I use by rebuilding the incus. Always use the nylon strut. This was just to show you that even though you've got a small soft tissue connection, we prefer to rather use a nylon strut. And this was just that to show, in our congenital middle ear cases, it's a really nice tool to use. I'm just going to, for sake of time, fly through that. That was just some congenital cases. So, just a little bit of our results. We've used Ketochem in 587 cases since 2009 officially. This was a little study I did to myself, but I think it's a little bit biased because I wasn't, those are the early days of 50 torps or porps compared to the Ketochem cases. So my last 50 cases opposed to my first 50 cases. So there's probably a couple of years in between of experience as well and getting better at your surgical technique. So there is bias here. So although I've put it out there, I don't know if you can take much from that. We had a 13.6 decibel overall average air-bone gap improvement. And our best outcomes were in the Austin Cartouche B and D groups. So as I've said, IS joint disruptions, minimal ossicle defects, which you saw, especially ossicle preservation techniques. If you want to keep those ossicles and you want to try and just use something, you can always remove them at a later stage if you need to. Obviously, the eroded incus and the revision stapes. Those are our indications, and I want to stress this is a backup tool in theatre. It's great to have it. Don't make it your primary method. But, if you open an ear in South Africa, we don't have the privilege of having 17 different prostheses that we can do this or that or this or that. So it's a very nice extra added benefit to have this in the cupboard so that if I open an ear and there's something that I'm not too happy with, or I have a type of prosthesis that I can use by using the cement. It shouldn't be a compromise for poor technique. As you can see, revision surgery very possible. And mistakes can be quickly fixed. So thank you for your time. Questions? Yes, Anis. Rob, yeah.
Thank you, Dwayne. It's a fantastic expose. I was interested, do you take the mucosa off?
It's actually a very good question. I know Chris was saying that he prefers to laser it. On this specific cement that we use, if you just dry it a little bit, you've got 20 seconds where if there's no water or fluid attached, it doesn't affect the drying properties. And so we don't laser on the ossicle itself, or scrape, but I do scrape the mucosa a little bit back. You'll see that normally the mucosa is already a little bit, dried out and eroded, but we will move the mucosa a little bit back, but not necessarily laser it.
Because with that congenital case you showed,
yes,
it didn't look.
Oh, sorry. You know what happened there? I was actually the incus was. Sorry, I should have showed you. The incus was in two places removed, two places loose. So it was like an incus, stapes, and then a middle piece that was loose like this. So that was actually removed, and so on the mucosa slightly. It was glued with one nylon strut down. Sorry, I should have showed you that.
No, that's great. Just an observation. Is this working? In our experience in Melbourne, we used, I think it was called Serenochem, ionomeric cement.
Yeah.
And I was doing exactly what you were doing for the revision stapedectomies, for example. Put a prosthesis further up the incus and then reinforce with Serenochem. And then, exactly like the one case you showed, I found that there was a significant incidence of them falling off, and in fact, even progressive erosion of the stump of the incus.
Yeah.
And so we have abandoned using ionomeric cement and now only use hydroxylapatite cement, which seems to be more stable, at least in our hands. So whether it's the different manufacturer or different system to Ketochem, I'm not sure.
So I definitely think there was a difference because with Chris we saw that erosion with the Serenochem. We haven't seen that with the Ketochem. And Rob, I used hydroxyapatite in the beginning to try and compare the two. We didn't get a great result with hydroxyapatite, and it's really more expensive, so much more that it's just not worth paying for.
Yeah, just to comment on that, I've used it's called Otomimics, and it's I've abandoned it. I used it for years because it was the only thing the hospital had, and you don't often have choices, in any setting. You don't have choices. The hospital made a decision, and that's what. And also, you don't really know how. You can't go out and sort of side by side take this cement, then that cement, and so you have to share with experience like this that you've showed. I think the hydroxyapatite is worse. It's much more brittle. It's very easy to crack it, like
Cracks
you were
much
showing.
easier, yeah.
And then it also, I think it also deteriorates a bit over time. So I think the cement you're using is very good. I was going to also ask you that that solution, there is a problem that really doesn't have a good solution when you have a shortened incus and you're doing a revision stapes, and it's an unsolved problem. I know that there are techniques that everyone thinks is their favorite, but it's not reliable. And so, but this technique that you're showing is really quite simple, and I think it's great. I don't know if you've published the results that you have, but
badly not, and it's just because it's in private practice and it's me only. I don't have a reg. I've got a fellow now, but she's
you should, because this is an easy solution, and if you seem to have good results. All these prostheses that are made for this solution don't work really. So I think it would be great if you publish that.
Good, encouraged. We'll do that. Another question, Joachim.
Yeah.
Or who?
Oh, first.
Anna.
Hi. Sorry, that was a really good presentation. I just wanted to echo what the rest of the faculty has already said about hydroxyapatite. So we use Otomimics, and it's a single mix. And I think from what I've seen and from my seniors, it tends to fall off after some time. Do you know if this is available in the UK or in anywhere else in Europe?
So this is made in Germany.
Right.
And I flew there to try and convince them to allow them to use it CE, and they said it's not worth the money to make it CE marked. So it's made in Germany. It's available in the dental industry in Europe. But you're going to have to use it off label.
Right. That's interesting.
Sorry, man. We've tried. I went there myself, and they just threw their hands up. So look, it was bizarre, but I was doing this and I presented once, and Levant came up to me afterwards and said, Dwayne, I think we reinvented the wheel together, because this is the exact same cement Levant has been using for all the years. So the Turkish guys use very similar. This is the same thing that the Turkish group uses.
It's really nice that it's stable for you.
It's stable for long, and it's quick to dry. I know that's a problem, but it's for us surgeons that are irritated, and we want the thing dry so we can close up and carry on. So it is very helpful that it dries fast.
Just wanted to mention that Grace Medical, I use the Grace Medical cement. It's called ProSem. And I think it's available everywhere. It's a bit complicated because you have to have a little machine in the OR that they're doing. I'm not exactly sure what it does, but they have to mix the materials Maybe it's not
So
a
there's-
centrifuge, but
So
it's,
one of the problems is some of the guys need a centrifuge.
yeah, that's what. No, I think it's a shaker.
And
or something.
the other one is some of them need a light to cure it. A special UV light has
I-
to strengthen.
yeah, I don't
and
think
that's
it's
why
a
I've
light,
stepped
yeah.
away and I've tried to use
Yeah.
something that was just
Yeah.
easy and doesn't have those two properties needed. Sorry, I've taken too much time. Question, Joachim, yes.
Yeah, I was asking about the registration for use in otology. You know, I love this technique, and Ketasem comes from Germany.
Yeah.
Basic research was done in Pretoria with Gaia and others. And one of the problems is aluminium dilutation out of the process. So you worry about the inner ear is right. It does not work for the small cement in our hands so good, but maybe the core makes a difference. Can you comment on the lenticular process when you do the reconstruction? Do you preserve it, or do you put it directly on the head of the stapes?
So if you, what do you mean by that? If the lenticular process of the incus, I'm going to I leave it as it is and I stick it on top of it and just extend it. So, but if it's a small gap, obviously we don't, we just go from directly to the head of the stapes. But I haven't found that. There's those small little gaps that you can probably just put a dot of cement without a nylon core. Sorry, I'm not quite understanding what you're asking.
Yeah, well, but if you have the defect,
Yes.
and if you have the lenticular process, do you put it on the lenticular process and keep the joint between the lenticular process and the head of the stapes intact? Or do you put it directly on the stapes? Because the surrounding is not completely dry.
Yeah.
Then you will have erosion of the stapes superstructure. And, how do you get it dry?
So what's very interesting is that's the one cement that we've tested that was the most favorable in slightly wet conditions. And so if I do reconstruct that, inevitably, if I'm doing the lenticular process, very seldom that I can fix from the incus body, and there's a small piece of lenticular process with a joint, and I'm gonna just fix the incus. No, I inevitably include the joint in the encapsulation of the cement. And yes, I probably will be a problem, but if you think about it, it then acts sort of like the porp does, that just sits on the head of the stapes. We haven't seen erosion of the stapes, but it's possible.
Well,
And it is difficult to get it dry, but it sticks quite well there.
Thank you.
Okay, thank you. Sorry.
This is the moment you've all been waiting for. This is the Oscar ceremony. So, in no particular order, so we don't want to give anything away, we've got 3 presentations. Oh, yes. So, we're going to do the posters now, and then we're going to have a break for coffee, and then we're going to have the round table. And in the round table, we're going to have some questions for you guys. So, if you go to polleverywhere.com, you'll see there's an app there for your phone, and you'll get the link to it'll be Christopher Aldrin 295. Once we get going with the presentation, the questions should automatically come up onto your phone, and as we go through, you'll be able to click your answer to the various questions. You'll see how it goes. I'll see how it goes because I've never used it before, but hopefully it'll work. So now we're going to do the posters, and as I say, this is not in the order of how they've done, but have we got Myong Sin Kang here? We haven't got Myong Sin Kang. Okay. Have we got Noah Ahmed El Kholi? So, we would like you to come and just tell us a little bit about endoscopic ossiculoplasty in traumatic conductive hearing loss. Oh, this is the money. This is the money.
Good morning. I'm Noha from Egypt. Firstly, I'd like to thank the organizing committee for giving me the chance to present my research. I'll speak about the endoscopic ossiculoplasty techniques we use in traumatic conductive hearing loss with an intact tympanic membrane. This is where I work, and these are my co-authors in this research. I have no conflicts of interest to disclose. If you want the whole research, you can email me at my contact and I will send it for you. Firstly, a small introduction. Traumatic ossicular injury is a frequently encountered finding after head traumas, especially road traffic accidents, which we had a lot. Conductive hearing loss in these cases with an intact tympanic membrane represent a challenging situation because you cannot see what's inside the middle ear. So in this situation, you have to detect the exact ossicular pathology, and also you have to tailor your management according to each case. Like Professor Robert said, it's case-by-case scenario. So it's not only about your surgical skills, it's also about your decision-making. So you need to plan. In these cases, failure to plan is planning to fail. So how do you plan in these cases? Firstly, we used to do a preoperative radiology, specifically a 3D reconstruction for the ossicles, which gives high suspicion results for what we will find in the middle ear. After that, we can suspect the possible pathologies, and after that, we will plan what we will do for the case. So the aim for our research is to present a simplified approach for the endoscopic reconstruction of the ossicular defects, and also to demonstrate the beneficial role of the 3D reconstructed images. Our included cases are those having traumatic conductive hearing loss with an intact tympanic membrane. It was a retrospective study over a 5-year duration in my tertiary care center. All cases were managed by a transcanal endoscopic approach. The bone cement we used in these series is a gold label glass ionomer. It's a Japanese one. The radiological studies done were 3D reconstructed images and were interpreted by a senior consultant radiologist. Success in these cases was described as having airborne gap postoperatively less than 20 decibel. So this is our simplified approach. We have almost 2 possible lesions as the tympanic membrane is intact, so there is nearly a rare possibility of having a completely lost ossicle. So you will have either joint lesions or ossicular lesions. Ossicular lesions can be a fracture or necrosed part of one of the ossicles, and joint lesions are usually subluxation or dislocation of the joint. So basically the algorithm depends on either bone cementing the fractured ossicle or repositioning of the dislocated ossicle, reforming the previous joints and then fixing it by bone cement. This is not to say that we don't use prosthesis, but it is a simplified approach for managing these cases, as the various type of prostheses are not always available. The only prosthesis we used in this series is Teflon piston in case of a stapes fracture. As we heard in the previous lecture, there are various materials used in reconstruction. The one used in this series is a bone cement. This approach depends on reconnection of the ossicles in the least synthetic, most naturally, and also cost-effectively accepted way. So this is one of the cases we managed. The first one, which is figure A, represents a 3D reconstruction of the ossicles. You can appreciate the presence of the malleus connected to the incus with a necrosed longa process. And this longa process is separated from the head of the stapes. And this is what we find inside the middle ear. The star represents the foot plate. The stapes is separated totally from the foot plate and also from the incus. So what we did in this case is we did a bone cement elongation of the incus, followed by positioning of piston teflon and then refixation by bone cement. Maybe later I will try the nylon technique. The second one is so simple, just incudostapedial dislocation, and we fix it by cement, bone cement. The third one, we can see in the 3D images that the malleus and the incus are subluxated. This space means subluxation, and also there is no connection with the head of the stapes, and this is what we find inside the middle ear. The incus is dislocated from the malleus and also from the head of the stapes. Simply, we repositioned it into its position and then fixing the two joints with bone cement. Okay. Okay. Sorry. Okay. Okay. I will finish. It's just a representation of our experience in these cases, and we encourage doing a 3D reconstructed images in these cases. Thank you.
We got Sophia Gantner. So we really just want a couple of minutes just so you can sort of summarize. That'd be lovely. Thank you.
Good morning. So thank you. We appreciate the opportunity to give you a quick overview of what we are currently doing. First, I would like to thank my colleague Andrea Schreier. We started this project together. In the last years, MRI became more and more common in follow-up after the cholesteatoma surgery, and has shown detection rates up to 90%. So we wanted to verify if this applies to the setting in our clinic. So in a nutshell, we are comparing two different MRI sequences from two different MRI scanners regarding the diagnostic accuracy compared to the pre-op clinical findings and the intraoperative findings.
So we started this prospective study and included all cholesteatoma patients scheduled for surgery, and all got two different MRI scans preoperatively. And as a control group, we also recruited patients scheduled for CI surgery who did not have any middle ear disease, and they also got an MRI scan preoperatively. And what we found was actually quite surprising, because despite the results in the literature that show quite high detection rates for MRIs for cholesteatoma detection, we found considerably lower detection rates for cholesteatoma detection via MRI scans. And around 20% of the cholesteatomas were not detected via the MRI scans, via both sequences actually. So as you can see, we had a false negative rate of around 20% in both sequences. So we kind of conclude that otoscopy and second look surgery remains crucial in the follow-up after cholesteatoma surgery. And at least speaking for our clinic, MRI alone is for now not sufficient for good surveillance after cholesteatoma surgery. So thank you very much.
Other poster, but quickly this time. Endoscopic tenotomy in Ménière's disease.
Endoscopically. Yes. So I'm going to speak about endoscopic tenotomy in Ménière's disease. Is it effective or not? These are my co-authors. I have no conflicts of interest. We all know that Ménière's disease has a controversial pathophysiological aspects with indefinite treatment options. I will not spend time in discussing the pathophysiology, but I will speak about the theory behind tenotomy. They stated that the pressure inside the endolymph, or the cause of increased endolymphatic hydrops, can be eliminated by 3 routes, either vestibular aqueduct, round window, or oval window. So the theory of tenotomy depends on destabilizing muscle action inside the middle ear. So this can alleviate the pressure over the oval window, allowing for lateral expansion of the middle ear. They said that this can reveal pressure over the inner ear structures. There are advocates and opponents of this technique, and advocates are strongly defending this technique, saying that it can have a dramatic reduction in vertigo attacks, and recurrence of symptoms can only be explained by a scar tissue connecting the tendons again. In the aspect of Ménière's disease, both positive and negative results are equally valuable to decide whether to offer this treatment option to the patients or not. So our experience in this aspect, we did a retrospective study discussing patients with definite Ménière's disease. All patients were managed endoscopically by cutting the tendons of tensor tympani and stapedius muscles, and they were all done under local anesthesia. These photos represent identification of the stapedius tendon, then cutting it. The second one shows stretching of the tensor tendon behind the malleus, and then shows it's completely cut. This star represents the cochlear reform process, and this photo was by 30-degree endoscope. We had a follow-up period slightly larger than 2 years. We had no significant complications. The early results showed significant improvement in the frequency of vertigo attacks, complete or class A control of vertigo in nearly 57% of cases, and substantial control of vertigo in nearly 17% of cases. When doing Kaplan-Meier survival curves to detect whether these results can be reliable or on long-term follow-up or not, we found declining results for the cases, either for complete control or substantial control. There are 2 main concerns with this technique: that the long-term survival results cannot be guaranteed, and also those results are nearly like the intratympanic steroid injection results. So at the end, we cannot consider the middle ear tenotomy as a definite treatment for Ménière's disease due to its poor long-term results. And if it's offered for the patients, it should have realistic expectations, unlike published before. Thank you.
Okay. So thank you very much. And if the German ladies can come up as well. So we've got 3 prizes. So in reverse order, have a little look. We've got, that's the gold, and the bronze, and the silver. Okay. And not only do we have awards, we've got money. So in reverse order, in 3rd place. Oh. Okay. Yeah, no, it's just that I thought there'd be different amounts of money. So in 3rd place, with endoscopic tenotomy, we have Noah. So do you want to take a photo? Let's have a photograph. Okay, don't go away, because in 2nd place, we have Noah and traumatic ossicular. And in 1st place, we have the MRI pursuit of cholesteatoma. Thank you so much. Well done. Congratulations. And now we're going to have a break for coffee, and then we'll come back for the round table. waiting for things to load up here. So I'd like to invite my panel. So we have Diane, please. And Oswaldo, unfortunately, isn't here. So we're really scraping the barrel here. But we've got Saji coming to represent Brazil. And for the home team, we would like Thibaut. So please have a seat. Yeah. Right. Okay. And then we would also like to have Preppa. Thank you very much. And Nirmal. And Rob. And Jose Carlos. And Neil Spilling. And we'll have Dwayne. No, Dwayne? Take a photo. Okay. No, we need one more. So I think... Oh, no, we're fine. We're absolutely fine. Okay, guys. So we're going to do... look at some cases. And have we got some mic? We've got microphones. Great. And we're hoping that this poll everywhere thing will work. I honestly don't know whether it will, but let's have a little look first. So you should be able to either go to your app or just photograph the QR code or log in. If you're on pollev.com, it's Christopher Aldrin 295. That's not my age, by the way. Okay. And so once you're on there, hopefully you should be, if you can let me know, is it working? And can you just click your answers? You've clicked. So we've got one person. Christopher Aldrin 295. So we've got some people. Yeah. Sorry? Yeah, everybody can do it. I just want to see if it works, really. And also it'll show us whereabouts in the world you're waking up. Yeah, it works? Good. That's great. Now the question for me is how do I actually see the results? But I'll let you all load up. Okay. All lowercase, John. Very good. Or there's a QR code. I knew this would cause trouble, particularly with the older members of the faculty. We'll be here forever with them. Okay. Now, what I want to know now is... Ooh, hang on a second. The question is, how do I see the responses? Oh, there we go. Okay. So Neil obviously hasn't answered because there's nobody from North America. You've answered a few times, but we've excluded you. Okay, but we've got it. I just wanted to see if it worked, and it seems to work. So that's good news. Great. Okay, so I don't know if we got sound on here. Do we have sound? I hope we have sound. Let's just check, because some of you were at the dinner last night. We need sound for this. Is that? Yeah. Okay. Let's. It's gonna work. Yeah. Perfect. Yeah. Is it? No, you have to. It's a little bit. So current slide. Okay. The poll's full. Brilliant. Okay. So those of you who were there last night, I think you enjoyed the wine, but this is something you probably need to know about the wine. I hope this will... Oh no. What is happening? Here we go. Let's try again.
Cet appareil est le USB Wine et c'est génial. Et maintenant, vous aussi, vous pouvez accéder à cette extraordinaire technologie depuis chez vous. Regardez comment fonctionne cet appareil révolutionnaire.
Vous branchez l'USB Wine à votre ordinateur.
Vous accédez au Wine Store dès votre USB Wine connecté. Vous visitez les meilleurs vignobles dans le monde d'un clic de souris.
Vous choisissez un vin et commencez le téléchargement.
Votre vin se verse directement de l'USB Wine dans votre bouteille.
Et vous avez en plus l'étiquette. Waouh!
Quel
So there you go. That's how it all works.
Et durant...
Okay. And they're only 10 euros, those. Good. So the first case, this is a very straightforward case, guys. It's a 30-year-old male, right-sided, conductive hearing loss, air conduction 44 dB, 30 decibel conductive hearing loss. Left ear is normal. Actually, I'm just going to come out just for 2 seconds. Just bear with me a second. Sorry, I just need to get onto my... Okay. Well, we'll just go back to that. Not to worry. Okay. So, we're going to do a poll now, and then we're going to go around the panel and see what they do, because I want to know what the audience does first. So, what is the operative approach for this? Well, we'll talk about that as well. Yeah. Is it okay? Yeah. Yeah. Okay. So we've obviously got some Germans in the audience because there's an end-oral approach for this case. And as I've said to you already, that's completely unnecessary, but there we go. Per-oral and post-auricular. Great. So we're going to go to the panel now. Let's go back to the case. And I think we'll start off in Sydney. So what's your chat with this? He's got, I mean, it is retracted. It doesn't look a particularly nice drum, but it's clean. So we're only really dealing with the hearing loss here. So what happens in Sydney with this guy? Yeah, no, but hearing aids is I mean, yeah, take the microphone.
Assuming we're having surgery.
Yeah, but for obviously you have the hearing aid discussion.
Yeah.
Do you push them for hearing aids in something like this, or would you? I mean, or would you fancy your chances with this one?
No, I do offer it to them, but a 30-year-old most of the time
they're going to go for surgery. So what's your surgical approach for this then?
It would be an endoscopic approach using the microscope as well. It would be transcanal permeatal, and I would think of one of two options: either stacking cartilage and like a piece of cartilage and then a second piece on top of that for the retraction, or a clip-in cartilage.
And how do you decide between those two then? You're there in theatre, you've lifted it up, you've got a thin drum. How do you decide which?
Probably the biggest factor would be insurance. Actually,
yeah, but that's an important thing, isn't it?
So if they were self-insured or they were money was tight, then we would avoid the clip.
But the clip is what? How much is it in Australia? $400?
It's about 400. Is that right?
Something like that.
I think it's about $400.
But the whole cost of that for the self-pay patient is thousands, isn't it?
It is thousands.
So do you think the 400 does it make much difference? I don't know. Okay,
certainly
fine.
argue it doesn't make much difference.
But you're going to put some cartilage on top of that.
Yes.
Yeah. Okay. It's quite a small defect. Let's just go on and have a look at it. That's what it looks like when you lift it up. So we're going to go to, I think, let's go over to Saji, to Brazil. No, we were really struggling actually.
Yeah, well,
if there'd been anybody else, Saji, I would have chosen them.
This case can be a little bit more complicated than it looks like, because you have two different approaches here. The pathology approach, that you can put whatever you want there, cement, you can put a piece of bone chip or whatever.
We know that, but what would you do?
I would, no, that's the point.
Yeah.
And the second approach is the pathogenesis approach.
Yeah.
Because the big problem here is not the ossicular disjunction, it's the retraction.
Yeah.
So you have to know how to deal with that. So to put the same, to make a long story short, I would go with an underoral approach, and I will try to build up this probably with cartilage, with two different reasons. The first one was to restore the hearing as much as possible. The second, to have a better and more rigid tympanic membrane posteriorly. So we have two problems.
Yeah.
The retraction and the disjunction.
And your top piece of cartilage that goes under the drum, is that just cartilage, or does it have perichondrium on it?
Well, sometimes you have perichondrium. You can use the perichondriums, and comes to the ear canal, so you can use as
and that's what we call an island graft, yes? So you keep the cartilage, but you have a sleeve of perichondrium
and then the cartilage would be, under the tympanic membrane, remnant, and then on the top of the stapes with both.
And do you thin it?
Most of the times, because we need some fake cartilage here, because they have to get to the stapes and to the tympanic membrane. Problem is I wouldn't thin it. We're going to take it from the tragus and insert a little piece there.
Yeah.
You know, not so little because I need to cover the tympanic membrane, the posterior superior quadrant of the.
And if you're going to
membrane.
put cartilage on that and strengthen it, what are you doing with the incus here? How does that?
You can kind of drill the tip of the window or of the incus, or if you are convinced that probably you're going to have a reaction that year, the easiest way to do is to do like Dwayne does. You know, use some cement there.
And do you have you have cement available in
ionomer of glass? We do have.
Okay.
Yeah.
Okay. And how about the approach in the clinic here?
For myself, I should perform a large reinforcement of the tympanic membrane with cartilage because first the problem is the retraction.
Yeah.
And then under with a titanium port.
Yeah. And that's which one do you actually use in the clinic here?
The middle one.
The middle
clip with the
so that looks
clip.
very much like the Kurtz that I showed you. Yeah. Okay. Good. I think we're going to move on from that case. So. Yeah, well, we haven't finished the session yet, so you'll have your opportunity. So we're going to go to the audience now. So what do you do for this? Oh, we've done this, haven't we? No, we haven't done it. No. Okay, so what do you do, guys? Yeah, but it's fine. It doesn't matter. It's once we've got the full number. So Robert's not voting on this one, I don't think. Because I think I put that in for Robert. Oh, here he is. Too slow to vote. So okay. So there we go. So most people are going to go for a PORP, which is, I have to say, what I would do. And that is partly my experience with the cement falling off, and I think Dwayne has shown us maybe a different technique, but my experience is cement's brilliant until it falls off, and then it's obviously useless. So I did use Serenacem, which, as many of you know, that company's gone bust thanks to me, but hydroxyapatite, I gather, also fails. I was told that it didn't fail, but maybe the Ketocam's the one to go for. Okay, that's great. So, and we've also got a few points for incus interposition, and we're going to come back to that. So this is it's a similar sort of case, but the retraction's not so deep. But the big difference here is the hearing's pretty good, really. So the question with this lady, she's 63, she's a little bit fed up with her hearing loss. But what would you do for her, Diane? And she's wealthy. She's got her yacht parked up in your harbour. So money's not an object here. What would you do for her?
Does she have otorrhea? Is it?
She has no otorrhea. It's a dry ear.
Dry ear.
Yep.
Never experienced anything, even when she goes to swim and everything. No
No,
trouble.
she has no problem. The only problem is that she's not hearing so well in that end. She doesn't like that.
Of course, I will talk about prosthesis because she has a mixed hearing loss.
By the prosthesis, do you mean a hearing aid?
A hearing aid, yes.
Yeah, okay.
Sorry,
yeah, and she's she's really wealthy, one of your normal patients, a billionaire-ess, but she doesn't want to hear. She does not want a hearing aid.
Well, I will. She really wants surgery.
No, she's come to see you. She doesn't want a hearing aid. The question is, will you operate on her? That's what this is all about. Will you operate on her? She's got a 15 decibel airborne gap. Do you remember when we were talking about ossiculoplasty, we said a successful result is getting you within 20 decibels. So my question for you is, what's your minimum airborne gap where someone can persuade you to operate? I mean, this is quite a nicely ventilated ear, but she's got a type 3 tympanoplasty. You know, what's your chance of doing better than that?
I will offer to see her again to see how the eardrum evolves.
Okay, so it stays the same, and she's back, and she says, "Look, can you do something for me? Okay. I heard you're a famous surgeon. I want my hearing fixed." Sorry?
It's the patient's problem. She wants. It's one thing. She gets. It's completely different.
That's
so
why.
That's
why I've got an international panel here.
I don't want to bring her problem to me. I mean,
yeah.
If she wants to hear.
In Porto Alegre, she's not going to. If she comes to Porto Alegre, what do you say?
She won't have surgery. She will not have surgery because when you talk about stape surgery with a completely normal middle ear with full of air,
Yeah.
then we're going to wait for a 25 dB gap. Here we have 20 with a middle ear that is not
15,
stable.
15. Yeah. Okay.
And
So this is what we're interested in.
One more thing. There, in the other side of the coin, we have done a study. We call this tympanostapedopexy. It works like a type 3 tympanoplasty.
Yeah.
We went through 50 cases, and indeed, the results are like this.
Yeah.
But the other side of the coin, we found 28% of years with post-superior cholesteatomas.
Yeah.
So that's
Okay.
it's a
But
big-
this is the cleaner. The question here, really, for the panel is, what's your threshold for the patient? So the patient's got nothing wrong with them apart from an air-bone gap. What is your minimum air-bone gap where there's nothing else going on? It's purely about hearing restoration. What's your threshold for operating? So that's what and therefore, if you want to answer that question, you have to know your results. So you have to have a database, because the next question from the patient is, what's the chance of it working? And so let's ask Prepper, what is your answer to that question? At what point would you operate on this? I mean, there's a lot of money. This patient's got lots of money.
These are the kind of patients that you want to avoid.
Yeah.
I would not operate on her at all. If you look at the higher frequencies, the air-bone gap is 10.
Yeah.
So I will not be able to close the.
So would
air-bone
any of the
sufficiently.
panel operate on this lady? Jose Carlos, I knew you would. But that's only because she's got lots of money, isn't it? Come on now.
It's not because of that.
It's the people with money is the problem.
Jose Carlos has a very expensive lifestyle. I mean, look at this guy.
It's very important to hear the patient. When the patient comes to your office, it's because he looks for something. So she wants to not be operated. She wants a solution for her problem. She got a problem.
If it's a
It's not my
bilateral
problem, it's her
conductive hearing
problem.
loss, then I think at least it's worth considering.
Yeah,
You
but
have
I
a
have-
normal ear on the other side.
Yeah, but maybe this 20 decibels of gap is going to going better with just a straightforward procedure.
But on the other ear is normal, so whatever improvement she got here is not going to be so obvious
But
because
she's
the other ear is normal.
perceiving a problem in the right ear. So you have to listen to her. And maybe I can convince her not to touch the ear, okay?
But maybe can she convince you, though? Can she convince you to operate?
She'll pay you thousands of
medical
euros, so
indication
it's
is
okay.
there's a gap there. There's a gap.
So this is what we want. We want a full-on fight between the fuckers.
And it's so easy to go straight forward.
But
let's put the cartilage.
Let's take them.
Let's take it.
I knew Saji would be trouble.
And I don't mind the lawyers.
But you would operate if she really wanted you to.
She has a problem.
Yeah, she's got a problem,
You know?
but she's got a minimal problem.
the problem is
And
here
maybe the
or
best
here,
thing
but-
is to say to her, actually, the chance of making this better is small, and there's a significant chance we make it worse. But maybe I'm asking, would people operate on this? Is anyone in the room would be persuaded to operate? A lot of money you can get. Yeah, okay.
No, because of money.
Can we have the microphone over to the audience? Sorry.
Yeah, sorry,
Yeah.
hi, I'm Catherine from Australia.
Yeah.
So this is a woman who presents with eustachian tube dysfunction.
Not really. If you look at the
Yes.
anterior jump, she's got historic eustachian tube dysfunction. But if you fix her eustachian tube, that will lift off the stapes and make her hearing worse, presumably. Yeah.
I don't think so.
You don't think so? Okay. Okay, fine. But so what would you do for this lady?
So I think you optimize her nasal function. You do flexible nasal endoscopy, see what her eustachian tube's doing. Does she have large adenoids, which is a potential? Does she have something going on in her eustachian tube? You could consider balloon
she
dilation.
doesn't have any of that. Believe me, she doesn't have eustachian tube dysfunction. But I take your point. But she doesn't. She has had. But the point about this really is, if that was your post-op result, you'd be pretty happy. It's a clean dry ear with a small air-bone gap. That's a success for all of us here. So interesting. But the real question is, what's your threshold? So I'm going to go around all of you and ask you that. And I know it's all to do with other things like the eustachian tube. I know it's to do if they've got other problems. But these are patients who've got no other problems. All they've got is an air-bone gap. At what point, let's just take that exact case. How big is the air-bone gap going to be before you're going to be happy to operate? And you can all tell me that. And we'll start with you, Dan, because you have the microphone. Yeah, don't
I think-
hesitate. This is an easy question. Come on.
No, it depends on the DZ, but I would wait until 30 gap.
30 decibels.
Mhm.
So you'd be happy with 30 decibels. Any offers below that? Anybody going in at Let's be honest, Jose Carlos, we know you're at 15 as long as they've got enough
15.
money.
Sometimes I have 20, but I have the tuning forks.
Yes.
For me, tuning fork is a rule, you know. If
Yeah.
the tuning forks are giving me, you know, the transmission affected, and for me, sometimes I operate 20 decibels.
Yep.
And sometimes, you know, you get good results.
And
yes, but
sometime-
it depends on so many things.
So many yeah.
But if I would say the mean would be 30. But
30, yeah. And I think everybody on the panel happy with 30?
I would agree with I would offer it for
Take the microphone.
I would consider it for 20.
Yeah.
But it is multifactorial. It depends on the aeration of the middle ear. and
Yeah,
what
yeah,
the drum
yeah.
looks
Well,
like
we know all that, but the point here is that this is a good ear with a lot of things in favour.
Oh,
of it.
in
We've
the-
got air. So
in
that's-
that one you
in that
showed,
one,
I
yeah.
agree.
Yeah.
I wouldn't offer it.
Yeah, but if it
because
was 20 dB, you might.
then I'd consider it.
You would, yeah. Okay, that's good. I'm just wanting to know that. But the other thing I'd like you just to tell me is how you record your data. How do you know your results? Maybe you can all just briefly say that, just one word on how you do it.
Okay, I record every surgery in our Otology neuro-otology database.
Yeah, so that's
which
one
is
that you've
a mix of database and calculation sheets that calculate audiologic results, and
So
I implement each post-op
Yeah.
result.
So if you don't have a database, ondb.org is the one I use. It's the one from the clinic here, and I would really recommend it too. I think it's fantastic. Saji, what do you do?
Well, we record the results I don't have the database.
No.
I use the flow chart of the Excel.
Excel.
Yeah.
Okay.
At the
And
university.
Diane?
in Monaco, I do not yet record my results. I can say it. I'm not proud, but I'm honest. Yes, not yet.
I don't.
You don't record systematically all your results. And I just put it to you that if you don't...
Well, I have to tell you that it's illegal to do it. It's illegal. So in our university, or really in any organization now, you cannot record patient data in your own database.
Wow. Wow.
It's a HIPAA regulation. So if you're doing research, you have to get an IRB approval, and then you can do it.
But what about the cardiac surgeons? Do they not record survival rates?
I'm not saying it makes any sense. I mean,
No,
when I'm quoting it like
Yeah.
a stapes result, I have to know my and.
So how
don't
do you
tell
know,
anybody.
though? How do you-
I do have my own little database on the side.
Okay, so
but
if
officially,
if Donald Trump is if Donald Trump's listening this morning,
I have to
we'll-
stay in this country now.
Yeah, no, I've just said if Donald's listening.
I just heard that the Statue
He
of
doesn't- he
Liberty is
doesn't
being
record it.
deported back to France.
So, but you do that, and what do you use, Jose Carlos? With the microphone.
I used to use a database called ENT Statistics from Innoforce, but you know, lately I am a little bit lazy. I'm not putting into the database, and the hospital remind me the same that Neil told me that I can't hold a
You're not allowed to
database.
hold data yourself.
So,
but this is
you know,
a
push
huge
me a little
problem
bit.
for us, because I put it to you that, you know, I've asked you specifically this question about 15 dB, 20 dB, and you can only really answer that if you know your own results. It doesn't matter what his results are, or it's your own results, and you have to have that conversation with the patient. So, Diane, I want you to go home and get yourself a database, okay?
But I
It's
face
cheap.
the same problem in Monaco because the laws are very strange, and
But then
we
it
cannot
almost
have
makes it
whatever we
impossible
want.
for us to do our job properly, I think. Because,
I-
you know...
I fully agree. I
yeah,
fully
it's
agree.
very tricky. Okay, I've made enough on that. That's fine. We're going to go on now. So... I can talk without... Am I on? I'm back on again. Okay. Okay, it's because I was jumping. Sorry. Okay, so now we're going to go when there's more erosion.
Can I add something very quickly?
Yeah.
I think the hospital would allow to have your data storage in the hospital PC, not on your own PC. And that's the way to go
is
around
that
it.
the case, guys?
That's
No?
what I know
Not
from
in the
Europe. I don't
Principality.
know. Monaco might be different. Sorry.
Okay, so we've got our next question now. When you've got basically you've got a bigger erosion now. So that first one we looked at was a tiny little erosion. What are you going to do when the long process is completely eroded? We now know the answer is nylon and ketochem, but obviously we didn't know that before Dwayne's talk. Let me just... Well, it doesn't. It's basically up to 40. So we're just getting a sort of straw poll. But interesting. So again, the PORP seems to be the favourite here. So we're going to go on. We're now going to ask our panel. I think we're going to go back to Nirmal now. So this is a case where the whole of the long process is eroded, but the stapes is mobile and available. So what are you going to do for that?
And I've changed a little bit in the last few years because I do look at the status of the middle ear and the history of the patient in the context of the mobile stapes and the eroded incus.
Yeah.
And if the mucosa is very healthy, then they'll tend to be not a medialized malleus. The malleus they'll tend to be depth of the middle ear, and I'll tend to use a clip with cartilage on top.
And that clip is going straight to the drum. Yeah.
Well, with the cartilage cap.
Yeah, with a cartilage cap. Yeah.
And I use the scutum and the malleus intact to lock it into place.
Yeah.
If the mucosa is very inflamed and diseased, there'll usually be a medialized malleus.
Yeah.
And I'll tend to use cartilage then, type 3.
Okay, so you just feel that you're going to want more support for that drum, really, and that's why you're doing that.
More support, and also I just think the bad ears do badly, so it'll tend to retract and it might extrude the...
Yeah, okay. Rob, can I ask you what you do for this one?
Similar. I use a titanium adjustable PORP with a cartilage cap.
Okay. And can I ask you what the attachment to the stapes is like on that PORP that you've got?
It's not as secure as the Dresden style clip, actually.
So why do you use it then?
Because if you have a stable assembly with a vertical connection, it's very stable.
Yeah, until it fails. I mean, my experience with PORPs
until
is
yours fail. Mine, I've been very happy with my longer term results.
But when they fail, it's usually because they're not well attached.
A vertical stable assembly is very important.
Yeah,
exactly.
okay. Yeah,
exactly.
Yeah, yeah.
But also I would consider in some cases an incus interposition.
Yeah.
If it looks favourable and the alignment is good, then
so tell me about that then.
Well, if I'm happy that the vertical alignment is reasonable.
Yeah.
And the incus body is healthy.
Yeah.
Then I'll consider using an incus interposition.
And what makes you choose between a PORP and an incus?
Well, as Thibaut said yesterday, or no, maybe it was Francois, my laser assessment of the size. In other words, it's really a feeling I have whether or not it's going to fit. And there'll be some times when, in fact, I'll try and drill the incus and realise that it's actually too short or not going to give a good connection. Yeah, but if you've got good incus,
would that be your preference? Would you rather have an incus than a partial prosthesis?
Look, the advantage of an incus is that it is autologous.
Yeah.
Particularly if, like that first case you showed, where there is going to be a tendency for retraction.
Yeah.
The autologous incus is stable and secure, and some retraction around it is not going to be a problem. Whereas if you have a PORP or a TORP or something, and you get retraction around it, then I think there is a greater risk of problem.
So let's just give us a ballpark. You've got 20 of these. How many incuses do you do compared to PORPs, would you say, in your practice in the last few years? Just percentage.
It'd be less than 25%.
As of the incus?
Yeah, I'm more often using PORPs.
Yeah. Now, Sajid, can you tell us about what you use for this sort of situation?
Yeah, I use the PORP and with the cartilage on the top.
Okay.
And you also can use, two pieces of cartilage if you don't have the money to buy the PORP.
Yeah.
We're considering Brazil public system, so you don't have the PORPs. Then I will use 2 or 3 piled up cartilage pieces that from the top of the stapes to the tympanic membrane.
So you've disappointed me here because I thought you were going to tell me about how you would carve a piece of calvarial bone into a prosthesis.
Oh yeah, you can also do that. I like to do that basically when we're doing mastoid surgery, because then you have the whole cortical to do that. So we can carve, in situ carving the small prosthesis, and you can put on the top of the stapes, and even using as a TORP, you can use that. But you have to be very careful because this piece of bone has to be very delicate. You cannot touch wall structures with bone, because otherwise it becomes ossified and the results are not good.
So I've been told we have to move on a bit, and we could be here all day, but what I would like to, just a show of hands from the panel for this, how many people with their first preference would be to use incus? Yeah, it's okay. I haven't really got time to go. And everyone else is going to use a PORP? Yes? Yes. No. Dan, what would you use?
Cartilage.
Cartilage. Okay, fantastic. Good. Do you measure?
Yes.
Yes, you do measure. Measure. Do you use these little artificial ones to get the right size? Okay. Let's just have a little look. We'll maybe just... Yeah, what's the extrusion rate for prostheses in your series, Rob?
In an ear like that, it's quite high.
But do you know? Do you know that? Do you have that figure available?
To be honest, I don't, because although I do have a database,
that's not something you record. You only record successes.
No, I need to look at it and analyze it. Because it's one thing to have a database; it's another to have longer term outcome data entry. And it's another thing to sit down and analyze it.
It is, but when the patients walk in, they want to know what's the chance of it working. They want to know what the chance of it failing is. And I just put it to everybody, if you have your database and you have those figures, you should have those figures available. And you should be able to have that conversation. Neil?
The only comment I would make is I don't even really like this term extrusion rate, because it sort of assumes that it's the fault of the prosthesis. And really nowadays with biocompatibility, it's not the prosthesis that's the problem. It's the disease that's the problem.
Oh, no, for sure. Absolutely,
so
sure.
It's not an extrusion rate based on what you're using. It depends on the
But as far as the patient's concerned, they want to know about a sort of failure rate.
So
what's the chance of it failing?
But studying it means you have to study it in every individual, pathology, not just based on the prosthesis.
But you do. And when you have your experience and you look at that ear, and it's a retracted ear with no air, and there's no ossicular chain, and they've had cholesteatoma and it's discharging, and they say, what's the chance of success? You've got to be able to say the chance of success is very low with an ear like that.
I think you can say that without knowing
and for
exact number.
Chris, I implement my database since 20 years now, so I have a long follow-up, and I was extremely surprised to see that the rate of extrusion when there is cartilage reconstruction for the tympanic membrane, extrusion rate is 1%. It's low. Very little.
And that's with titanium, generally. Okay, just a couple of very quick questions. I think this one's for this is for you guys to answer. So you're in surgery, you've got cholesteatoma, it's all around your ossicular chain. It's eroded the incus, but it's around the stapes. You've done your surgery. Would you reconstruct at that stage? It's just a simple yes or no. Rebecca, have we got another 5 minutes, or do you want to... Are you happy? Because I think if we... Francois is about half an hour, and then we could finish at 12. Is that possible? Would that work? Okay, so that would give us another maybe 10 minutes. Is that okay? Yeah, great. Okay, good. Panel, just show of hands. How many people just generally always do reconstruction at primary surgery nowadays?
Well down tympanomastoidectomies. First stage is always. Well up, if I would plan a second stage, then I will go for the second stage. But well down, and 75% of our surgeries for cholesteatoma are well down. We do in first stage.
So let's just say we're doing. Do all the panel do canal wall up surgery? No, do you always do canal wall down? Always, okay. But for those who do canal wall up surgery, can I just ask you, do you all plan a second stage operation? No, okay. So quite a lot of us are going to primary obliteration and MRI follow-up and not doing a second stage. I was slightly shocked with Joachim's presentation, but when I actually speak to them, it sounds like some of those are cholesteatomas that are like sacs filling an open cavity, and you're not going to have that with. So I felt slightly better about that. But it is interesting. I'm very reliant on the MRI scan, so I never do a second look. Haven't done one since I've been obliterated. Okay. What's this one? Okay. So this is a 37-year-old male, cholesteatoma surgery, right ear, 10 years ago, with a TORP, which initially seemed to work pretty well, doesn't work very well now. He's got a normal, clear MRI scan, which I thought meant something. Left ear, hearing loss for 10 years. And at surgery, the CT shows that there's no stapes but a ventilated ear. So that's basically, this is a question, what do you do? We've looked at what we do when we have a stapes. Now we don't have a stapes. We've decided we're going to do the left ear because it's the worst hearing ear. So we get in, and that's what we find. You'll see that it's a mobile foot plate. There's a slightly eroded incus. Prepper, what are you going to do for this patient? We've decided on surgery. We've been dispensed with hearing aids. We're in there. That's what we've got. It's ventilated ear with a slightly eroded incus. Yeah, no superstructure.
But the foot plate is mobile.
The foot plate's definitely mobile, yeah.
So I'll just put a cartilage, just a small piece of cartilage, onto the foot plate, and it's within assembly.
So you'll put the cartilage onto the foot plate and rest it underneath the incus.
Yes.
And it just sits. It's not cemented. It just sits there. No glue. Okay. Diane, what do you do for this one?
A torp.
A torp.
A torp. Yes.
And does that torp go to the malleus or does it go to the drum?
To the eardrum with cartilage.
Drum. And which torp do you use?
The Grace Medical.
Grace Medical.
Okay. HA Light, is that?
Sorry?
HA Light. That's one of the hydroxyapatite head and a...
Yes, the Vincent's Grace, because I think it's really handy because, as it was said, if you're wrong in the size, because I don't have lasers in my eyes, I like to move it a little bit if it's too long or too short. So I think it's really handy.
Because that's a little bit of adjustable. Thibaut, what do you do for this one?
So it's difficult situation. I think in the real life I probably use a torp. But another alternative option could be if the incus remnant is long enough to put a piston on the mobile stapes.
But you've lost your lenticular process there. It's a bit eroded. Would you be happy the piston would stay on that?
In that case, I think it's too short.
It's too short. Anyone happy with with some sort of piston on that? Neil?
Well, the only thing I think I would do a malleus relocation. I mean, I think that would be a great case for malleus. I mean, we don't have malleus replacement prosthesis in the U.S., so we don't have that option. But malleus relocation will bring it right over the foot plate, and you can put a torp, like a fitted torp, under the malleus.
Jose Carlos? You'd relocate and then do a torp?
Relocation. Yeah.
Any other options? Anybody else got a good idea?
Yeah, well, I would do a malleus replacement, but in fact, Dwayne was sitting next to me. He's just disappeared.
That'd be good for his cement,
He'd build it up with a bit of cement and then maybe put a bucket handle just down onto the foot plate, no stapediectomy.
Rob, what would you do?
I think you want to aim for the most stable, longest term, reliable outcome. And I believe that a torp with a foot plate shoe provides that with a cartilage.
And what shoe do you use?
I've been using the Dornhofer shoe. And the Grace Medical adjustable torp with a cartilage cap.
Yeah.
And if you get a stable assembly, it's extremely reliable with excellent outcomes. For second stage mastoid intact canal wall surgery, the great advantage is you can use the endoscope to check transmastoid with a minimal approach to confirm alignment of your prosthesis and coverage with the cartilage cap.
Yeah.
And I've found that gives excellent outcomes.
Mm-hmm. Nemo? Anything?
Exactly like Rob, no.
You do the same as Rob. Okay, that's the Australian way. This is what I did. I put a bucket handle underneath with a little bit of cartilage stabilizer. Just out of interest.
That was made by Richard, and they don't make it anymore.
Oh.
So they make
there you
a
go. So you can't do that.
They make a titanium one, which is not as good.
Okay. Well, I don't know. Okay, we're moving on. So now we've got nothing. We've got no incus. We've got no stapes. So I guess you're going to do the same here. You're going to put a shoe and a torp. Yeah. What would you do, Prepper, for this? So there's a malleus, there's a normal drum, but there's no incus and there's no stapes. We've got a mobile foot plate. And what would you use? Cartilage. So it'd be great to see that. If we ever invite you back, maybe you could give us that talk.
Well, when you don't have prosthesis in your hand, for us, patients will have to buy before surgery. It's very difficult for me to tell patients you have to buy this prosthesis because I can't be doing the surgery.
But that's great. There are people in the audience who are got in the same situation, and so you use cartilage.
Yes,
would you use if you got a patient in Brazil who hasn't got access to the prosthesis? What would you use here?
I would use a torp in this situation, but you have to take care with the foot plate. I would put some tissue or a shoe on the top of the foot plate.
Yeah, okay. So the problem with torps, I think I said in my talk, is the foot plate. And the Dornhofer shoe gives you a very vertical assembly. And if it's aligned properly, it's really nice, but it's not always aligned properly. And then it actually pushes it in slightly the wrong direction. Does anybody have any good solution for stability at the foot plate? Any tricks? You must have a trick, Jose Carlos. Yeah.
I also use the cartilage that you show us, but I also use small chips of not only one, a small chip of cartilage around the prosthesis, trying to fix, a little bit in between the fascial and the promontory, if it's possible.
Okay.
It's not very decent.
Right. We'll not bother with that. We've done foot plate stability, so we're just going to come back now to our audience and ask you what you use to stabilize the foot plate, if anything. So a bit of a spread, but in favour generally of cartilage. And there is this Kurtz punch that punches out a little bit of cartilage, but as I said, you need to cut your cartilage thin for that.
Chris, you can also use a vein on the intact foot plate.
A vein
it
graft?
is like a carpet in the bathroom. It will prevent the sliding of the shoe of the prosthesis.
Well, I've never done that, so that's a good tip. Used a bit of vein. Perichondrium. Or vein graft on the foot plate.
The difference is that the vein is sticky. It will stick to.
Okay, so I think we'll probably make this our last case. I think so. This is a guy. He's been hit on the head with a baseball bat. He's not from Windsor. He's from Slough. From those in the UK, you'll understand the difference. And he's got immediate decrease in his hearing. And he's okay. He wasn't, he's unconscious for a short period, but he's fine. And we want to do a CT scan on him. And this is the CT scan. Who's going to comment on that for me? Neil, do you want to give me a comment on that? So he's got a fracture. Very good. Yeah, well, the stapes fine. So if you look at the other slide, is there anything on there that you can see? It's always difficult with a single CT, but he's basically got a fractured neck of his malleus, okay? So this is what he's got. You can see the fracture there through the wall of the canal, and you'll see in a second a really lovely fracture through the neck of the malleus. You can see the fracture there now, yeah? Just see how it's completely fractured just above the lenticular process. Okay, so what we're going to do for that, guys. So these stapes, the incus are fine, but there's that very clear fracture through the neck of the... What are you going to do Is it you in KL in Malaysia?
KL in Malaysia.
Yeah, in KL. What are you going to do in KL for that?
So basically the malleus handle is dislocated.
No, it's completely fractured. So just above the lenticular process, you maybe didn't see it, but there's a complete fracture through. So the handle is not... sorry, the lateral process, yeah. The handle is not attached to the head of the malleus.
Okay, I understand.
Yeah.
So that's going to be a bit of a tricky one.
Okay, well, you must have a lot of trauma in KL.
Yes, we do. But we just wait for a while. Within 3 months, sometimes heals on his own.
Yeah.
Sometimes it heals on its own.
So it might heal on its own. Yeah. Do you think I was a bit quick in there?
I would have at least waited for 3 months to see whether it heals on its own.
Yeah, it didn't heal on its own. Yeah. I didn't do that in the first week.
So what I will do is I will again put a cartilage on top of the tympanic membrane and put a small strut from the tympanic membrane right down to the incus.
Yeah, onto the incus. So a sort of augmentation.
Correct, yes.
Diane?
So you have to make a groove at the inferior part of the incus so that it sits on the
onto that groove, yeah.
And then the upper part is like a pyramid.
Yeah, okay. So this is really interesting to know what you do when you haven't got access to any prostheses or all the fancy stuff. Dan?
In Paris, we had not many, but few cases of fractures like this, and we had bad result with cement. So we're not using cement anymore.
You're not using cement? Yeah. So what are you using?
I would use a torp and keep the stapes and put my torp against the stapes.
Against stapes, like Robert's technique. It's nice that the French are sticking together. Thibaut?
So I would remove the incus and put a torp from the stapes head to the tympanic membrane.
Yeah, okay.
We'll do the same.
You do the same, okay.
And I'd consider an incus interposition again. This is a good case where you've got a healthy tympanic membrane everything's autologous,
Yeah.
and you don't need to get a prosthesis, provided the fit and stability is good.
Yeah. I mean, everything's perfect in this case, apart from this fracture. Yeah.
For me, cement is the best solution.
Yeah, I mean, I am not a fan of cement, but I used cement on this. It was absolutely brilliant. You know, it takes 2 seconds. You put a blob of cement. Maybe long term it doesn't work, but it's been working so far. I think we may be running out of time.
Excuse me.
Yes, yes, of course.
In this case, the patient has a mixed hearing loss, and the bone is thresholds are.
Yeah, well, he's 61. Yeah, so he's got age-related loss. But
even if you have a very good result, he's still have
there.
to use the hearing aid, right?
So I think it's a very good indication for a sound bridge on the stapes head.
It's what?
Case,
it's
a very good indication for a sound bridge on the stapes
sound
head.
bridge. Okay, all right.
Chris, what I did in this case, because I had several cases of trauma like this, and I used the malleus replacement prosthesis, the one you saw in my YouTube channel. So I put the MRP and put a torp at the same time, or stage the placement of a torp. But that's exactly what I do.
Great. Well, thanks very much. I'd really like to thank the panel. I could have spent all day here. It's been really great. Thank you so much. Thanks for the audience. We're now going to finish with our final presentation, which is from Francois, and it's about surgery for Ménière's disease. Is that correct? Fantastic. Thank you so much. Cheers.
Can I please ask you again not to forget the golden book? I put the golden book on the table when you leave the room. Okay. If you put the words, put your name and the country where you come from. Okay. Thank you.
Is it working? Yeah. So, hello everybody. Very glad to present now something about vertigo. I planned it would be interactive, but I think it will be a little bit shorty. So I have to choose. So this is for the presentation, my case of yesterday, because I think this case is a summary of what we have to manage when patient has intractable Ménière disease. This man was very young, 43, and the main problem was he wasn't able to work. So it means that it's a problem, economic concern, familial concern. So I have to give him a real response. He wants to be free of vertigo, and he is able to cancel, abandonner, oui, yeah, cancel his hearing. But the choose for him after 2 failure of gentamicin procedure was: do you want to be vestibular neurotomy, or do you want to lose completely your hearing? And he choose to lose his hearing, but it is not always the case. So what I would like to highlight is how do you make your decision making. And okay, I disclose, so except for neocondent, because I work with the Japanese company 10 years ago to develop cochlear monitoring. So what are we talking about? I think there is a strong mistake in Ménière disease, because in 1995 we have the American Academy classifications. She is a classification. In my opinion, it's the best, because it's very simple. You have the choice: definite, probable, possible, and what is not. And in 2015, the Barani Society make mix between the migraine, and some. And I think it's a very big problem. How do you choose your patient? How do you define your criteria for treatment? Because after, how do you compare the result if it is not the same patient? So in my opinion, we have to define what is a real Ménière disease, and we have to treat Ménière disease. And especially with the MRI protocol, which is available now all around the world, and particularly because a very famous team in Munich published this paper because Robert Gurkov take more than 200 people. All of them have symptoms of Ménière disease. Vertigo, oral fullness, tinnitus, hearing loss, mixed or fluctuating. All of them underwent MRI examination with the protocol. So there is people with symptoms and MRI positive. And they rewrite the story of the patient after. How were they at the beginning of the symptoms? So now, if we consider that, you have quite a third of the patients who don't have and who never experience cochlear symptoms, but they have vertigo and positive eye drops on the MRI examination. And the other fact is, if we have the cochlear problem, most of the time, it will appear before the vertigo, and the definite Ménière disease will be the end of the story, but in more than 60% of the patients. All of these patients have MRI examination positive. So I think it's mandatory to clearly identify our patient. This is not PPD, this is not migraine. And the migraine, the real migraine with the the American Academy of Neurology, if you use the classification and if you mix the patient, it is only 7% with migraine, real migraine, and Ménière disease. The other one is not the same. In my opinion, if you have MRI examination, if you have vestibular assessment, and if you are able to say this patient has normal vestibular testing during the intercritic disease, and if the MRI examination is normal with the eye drops protocol, so I think it could be a Ménière disease. In the other case, no. So the main goal of the treatment is restore balance, and for that, if we can, we have to preserve the residual hearing. So it began by treatment, but medical treatment. This is the protocol, the main protocol that I use. It is beta-histine for the first choice. I have to evaluate in 3 months if the symptoms, and I use the guideline of the American Academy, only the grade A, only for the in the classification, only class A, because in my opinion, B and C is not control of vertigo. E is control of vertigo, and the best is 0. So if at 3 months the beta-histine is not working as well, I had furosemide or acetazolamide, and I followed the patient, and 6 months after, I evaluate if he has or no, or if he has or if he don't have vertigo. If there is a failure at 6 months, it could be considered for the surgical treatment. So this is what I look for my first year in Causse clinic, and around 10% of the patient only underwent surgery. Most of the time, the medical treatment is working. So this is an icon made in Paris in 2017. And you know that this is quite the same. 80% of the patients are free of symptoms with the medical treatment, and some of them are get evolutive disease and intractable disease. So the patient has to be controlled by intratympanic dexamethasone. So when we see what is the cut, as we say in golf, the cut is the hearing. If the patient has good hearing, serviceable hearing, we have to consider conservative treatment. If the hearing is bad or not serviceable, we have to consider the radical treatment. You can use dexamethasone in all cases, but if the patient has intractable vertigo, and if you use the dexamethasone, you have to say that you have to say to the patient that it could be no long-lasting effect. So he has to choose what he prefers in that situation. So if we consider how is the risk for each arm of the treatment, the risk for hearing with the gentamicin is a problem. It is not well known, and you can find some risk between 25 and up to 40. And for the vestibular neurotomy, the risk is, of course, controlled. So, just a word. It is there is a strong relationship between the areflexy that you get with your treatment and the vertigo control. It has been well shown in meta-analysis 20 years ago, and for the vestibular neurotomy, it has been well shown. So, if we consider all the treatment, I would like to show you what I found. For the dexamethasone, I treat some patients. What I found is it is well working, but if we take the AOHNS guideline, and if we look for 2 years after the treatment, during the 2 years, most of the patients receive another injection. So it is working. Maybe it works during 1 year or a little bit more than 1 year. The other part of the conservative treatment could be the endolymphatic sac decompression and the vestibular duct blockage. So this is the Salibas technique. I don't speak about this procedure because it's too long. Yeah? So how is it working in my hand? I found it's a really interesting treatment, but I don't know how it is working. So this is the problem. There are some studies in the literature who correlate the surgical findings and the MRI examination before and after treatment, and it seems that it could be related, but I don't know how it is working. And and when you hear Issam Saliba, he has a lot of explanation, but I'm not sure it is working like that because it's too mechanical. But it works, and it gives you some better effect as the dexamethasone, with a risk of hearing which is very short, very little, but not zero. So it's a problem. And after that, you can consider gentamicin, of course, because if we are with the hearing which is not so serviceable, we have to choose how to eradicate the vertigo with the radical treatment. So gentamicin is in that case. And the other one, excuse me. So what is interesting in that series, it is the hearing loss. It was not expected, and I was very surprised when I used it for the first, because three deafness or severe hearing loss with only j'ai pas de pointeur, with only 13 milligram. So I was very, very surprised. So it is one of the questions, but we don't have time, so I think I move after for the surgical treatment that I performed yesterday. So yesterday I performed surgical labyrinthectomy, and a question of Joachim at the beginning was why don't you insert cochlear implant in the same time? Because we don't have cochlear implant, but I fully agree. It's a very good indication, of course. But I would like to highlight a little bit on vestibular neurotomy now, because vestibular neurotomy is the only surgery which is able to give you 100% of good result on the vertigo attack and keep the hearing at the same level up to 95% of the case. So the series is like that. There is no recurrence of vertigo after vestibular anatomy or after surgical labyrinthectomy. And what is the good fact of that? None of the patients that I operate for surgical labyrinthectomy or for vestibular neurotomy call me back. Call me again. None. All the other treatment, they call back. So, for performing vestibular neurotomy, someone yesterday asked me how to be sure that the cutting of the nerve is complete. Yeah, this is the problem. We know that anatomically there is a cleavage plane between the cochlear nerve and the vestibular nerve, but if you can use something which is an help for your surgery, it could be electrophysiologic data. So this is one of the monitoring of the cochlear nerve that has been developed in the past. And 10 years ago, we worked with Jacques Ménière on this. So we have to insert a little electrode in the Luschka's foramen to be close to the dorsal nucleus of the cochlear nerve. And this allows you to record the action potential of the dorsal nucleus. It is used for the acoustic neuroma surgery, of course, but you can use it for all the functional surgery of the CPA. So you have to insert, dissect in the flocculus region, and after you have to insert the electrode inside. So this is the endoscopic view. The orange one is for the facial nerve, and we can check in the same time in real condition and in real time monitoring of the cochlear nerve and the facial nerve. So what is the result? What is the data with the electrophysiology of cochlear nerve? So when we check it, we can record a double peak, and the characteristic of this is double peak with less than 1 millisecond between the two peaks. This is cochlear nerve. If you are not on the cochlear nerve, if you are on the vestibular nerve, you can check. You can record 2 peaks or 1 peaks, but if you have 2 peaks, it is longer than 1 millisecond. So it's very easy, and this is the same stimulator than for the facial nerve. So you can check it. So this is a retrosigmoid approach, and we see how to check the both nerves. We know that there is a cleavage plane. Anatomically, there is a cleavage plane between the facial, the cochlear and the vestibular. But with the microscope and with the anatomy, you have to choose where is the cleavage plane. There is a slight groove, which is a little bit gray or difference of gray surrounding the surface of the two nerves, but it is something which is surgical experience. So with the electrophysiology, you can choose where is clearly the cleavage plane. So this is how to perform the vestibular neurotomy, of course, but in fact, in real time, how it is working. So we are checking. This is the cochlear. This is vestibular. So now I cut, I check, cochlear is good, vestibular, okay. So when I check just at the level of the cleavage plane, I'm sure that I'm passing from the cochlear to the vestibular. So this is the end for my presentation. We can talk about gentamicin because there is a lot of things, but I think I would like to answer to questions, and I would like to know how is your experience in that purpose of medical Ménière disease treatment. So what about, how do you consider all the treatment? What is your first choice? for intractable Ménière disease.
Just before we start the questions, just to explain the concept of the problem of the cochlear implant in France at the moment, because it's governmental financial support, it's only on a public hospital. That's for this reason, but it's going to change. It's starting to change, like for example in Paris with the Rothschild Hospital, but it's on the way, but it takes time. This is why François explained that we couldn't put a cochlear implant at the same time. François, Frédéric, we wait for you also. So any question?
And you know, yesterday I choose to perform my surgery by the posterior approach because I think I prepare the field for the cochlear implant. This is why. I don't perform the posterior tympanotomy because I don't need. But the incus is in place. I let it in place. I look for the third portion of the facial nerve. I dissect all the mastoid. You have the location for the processor at the upper part of my field. So if I come back to this patient to insert cochlear implant, it will be very easy. And I put some muscles in the cavity of the labyrinthectomy to be sure that the area of the cochlea will not be invaded by some fibrous. I hope.
Well, you referred to my question. I do not want too much pressure to you, and we have to act in the system that we have. But you mentioned fibrosis. We know from translab acoustics and middle fossa acoustic that the cochlea will develop fibrosis, and that's what we expect with labyrinthectomy as well. But nobody knows how quick it can be. Yeah. But from selected cases, we know that it can be quite quickly. Yeah. But maybe this gives a chance for you to put the pressure on the system that
it will be better now.
Yeah, that you have to do the cochlear implant in the clinic and you get the license.
We fully agree. But sometimes in the literature there are some publication of hearing preservation with translab. Do you see that? There is some case, and I have some case with posterior labyrinthectomy and remnants of hearing. So I don't know if the cochlea is working, but there is some remnants with masking. I'm sure.
I'm not sure. With in cholesteatoma, when we remove the labyrinths, we have seen some hearing preservation, but for labyrinthectomy, I would not expect it. But
no, it's not expected.
But maybe anybody in the room has an idea about the speed of fibrosis after labyrinthectomy. At the Prosper Ménière Society, it was also discussed as a primary choice in Ménière disease compared to endolymphatic sac surgery, which we do also in combination with cochlear implant.
We did a study in Melbourne where we retrospectively reviewed retrosigmoid and translabyrinthine acoustic cases and looked at the MR signal, and it was variable, the degree of fibrosis that occurred, and also variable in the delay. Sometimes they were fibrosed within a few months, and then you'd have trouble putting a cochlear implant in, and sometimes 5 years later they still had good signal and you can do an implant. And I've had one case where a lady had a labyrinthectomy 10 years earlier and was able to do a cochlear implant. Just a comment and an observation. I think gentamicin has effectively replaced vestibular nerve section, at least in my practice. And although I trained in Los Angeles to do nerve sections, and although I've since done 1,000 acoustic neuroma cases, I've not done a single neurectomy. And I believe that gentamicin's replaced it. And
when do you think it replaced it? Really?
Well, our approach is to use intratympanic by injection, and then if there isn't a response, then I would do what Wilco was describing, doing a tympanotomy and direct application to the round window niche.
We do the same.
And then if there's no response again, then I think about a destructive procedure. And I completely agree that a cochlear implant is in combination is the way to go.
I just want to show you.
One thing, an option perhaps for you is to put an electrode in, a dummy electrode into the cochlea, so that the space is preserved to come back and do a future cochlear implant.
Yeah, it's a very good idea, but we don't have. Just this is the last Cochrane library about gentamicin. There is no evidence, and nobody knows what is the harm. For example, hearing loss. How could you build a randomized control trial if you don't know if the hearing is able to be impaired? So it's very. How do you build your studies with gentamicin if you don't know what is the background?
But to come back to what you said, Rob, there was a study. If you compare transtympanic gentamicin or cerebral steroids to the round window approach, like we do here in the clinic, Silverstein made a study on middle ear exploration about the approach to the round window, and he found that in 40% of the cases there were fibrous tissue covering the round window. So in 40% of cases, transtympanic could not work. Interesting.
But even
not in 100%, it does. It works in. Yeah. Transtympanic. Anyway, he found that.
Through the oval window as well. So
yeah,
you don't have to have just round window absorption, and so
but
we don't know so much.
But the question is, how long does it stay there at least via the stacking tube? What we do, we are absolutely sure that it stays much longer. And I mean, we should compare the results. If Chris has good results with just transtympanic, we don't do it, so we can't say. But from a physiological point of view, let me tell. We make a hole in the eardrum and we drop them for 7 days continuously.
Yeah, and we put Jeff. But
they don't mind. We discuss hearing.
Merogel and system in the round and oval window, which concentrates the.
And all patients that go for Genta are counseled that they may lose hearing, and they prefer that way over the vomiting that they have every day. So they don't mind.
Let me show you. We use we have the both. We have transtympanic and intratympanic. It means we elevate eardrums. So I look for that.
Sorry, I just want to make a comment about intratympanic gentamicin. So I do more intratympanic gentamicin for the pre-acoustic translab patients as a prehab, and it's just an injection, no separate hole. And they will get the first dose a few weeks later after being a little bit wobbly, second dose. The third dose, I get ice cold gentamicin. And almost, I don't think I've had one person react to the third dose of ice cold. It's like doing calorics. And that's before they have their translab. So they literally, the anaesthetist tells us, you haven't done this patient with the gentamicin before because they react so badly when they get their translab. Whereas the translab that's had the pre-gentamicin, they all wake up not dizzy. So I know that's not for Ménière's because interestingly I've done it for Ménière's, only a couple, and sometimes you kind of go, oh, that hasn't quite worked because I don't think we take it all off with the gentamicin. So that's just a thought about, it does work because we do it for the acoustic neuromas, and certainly that's might be my experience with intratympanic gentamicin.
Okay, but there is a strong heterogeneity regarding all the studies, and this is a simple fact. I monitor my result, as Chris emphasized. I monitor, so I have this experience. This is a very, it is not published. It is a working that we have to publish, but this is only fact. This is with gentamicin for patient, and it is not selected patient. It is all of the patients are failure of other procedure, dexamethasone, endola fatigue sac decompression. So when they come here, we are a tertiary referral center. So it means that they have other treatment before, and it is not my treatment. So I use the gentamicin at that point. What is interesting with a main dose of 12 milligram, because what I want to do is, if I don't know anything, the only thing I know is the dose I inject. So I decide to inject no more than 10 or 2 milligram in one shot, and I see and I follow what is working. And with that dosage, I record 13 dB of hearing loss, mean average hearing loss. And if we go to the middle ear exploration in one shot, only one shot, 10 milligram, success 60, failures 40, hearing loss 13. So it means that with a single dose and a little dose, you have hearing loss. So in my opinion, it's a problem how to build and how to manage and how to conceal my patients. What I have to choose.
Can I have a question, please? What I find a lot with seeing Ménière's patient, that there is a very strong Ménière's symptoms in a lot of vestibular migraine patients. There's quite a close relation.
Close, but not the same, in my opinion.
Yeah, but they present very strong otological
but you have to
symptoms.
select.
But you cannot diagnose them as pure Ménière's, but they do have Ménière's syndrome, if you can call that. How would you treat that? I mean, yes, you can treat vestibular migraine with all the other protocols, but how would you treat those symptoms, Ménière's-like symptoms?
Only medically.
Only medical.
Oh yeah. In my opinion, no treatment for someone which is who is not Ménière disease definite. No treatment, no surgical treatment. No. And if the patient has only vestibular symptom, I need MRI examination positive for eye drops. If not, no surgical treatment, only medical. And in my opinion, if there is some doubt with the migraine, only medical treatment.
Only medical.
Maybe dexamethasone if you want, but
yeah, I mean, I do dexamethasone and they do respond. But
dexamethasone is very free. Very simple. You can use it. It's a little bit traumatic because it is not so easy to inject, and we have to go to the operating theater. That is what we do in France, because we need some anesthesia on the. I know that in other countries this is a desk
I do it
procedure.
In the local, I do it in the clinic.
Yeah.
Last question. Okay, last one.
Sometimes we ask for MRI for these cases. We found a loop syndrome, and the imaging said this is the cause of tinnitus or vertigo in these cases.
Okay,
or
you are talking about vascular nerve conflict.
Yes. So
you have
to
to
do
perform
in these cases?
ABR. If you have the imaging that tell you this is vascular nerve conflict, you have to perform ABR. If you have the increasing of the latency of the 5 waves, it could be related to your conflict. If the ABR is normal, it is not a conflict.
So
in my opinion, it's a cut.
It could be related to that. Yes, I know that. And you may find it on the other side also.
All right. I think it's time
Thank you.
to close.
Thank you very much.
Thank you, François. Thank you. So I think we wanted to be controversial. It is controversial anyway. It was one of the best questions which is controversial, I think, in this world. So I would like to thank you a lot for your contribution, your venue, and your contribution to this course. I think you are a real big part of the course. Without you, we would not be able to do that. And I think you will help us to continue this in the near future by talking about your experience here and sharing your experience, I hope. So several things before you leave. I remind you the Golden Book. It's important for us to have the signature, and don't forget to put your name and the country you come from. You're going to have a photo of all of us here, okay? And we will get that as soon as possible. And I would also like to thank the technological people from the Gael. Can you come? They did a great job. And I think, yeah, they need an applause. With Michel also, they were in the room, and you know, they are in the dark, but they're making a very big effort. So it's very, very efficient. They are from Toulouse, and so they are not so far from here. 2 hours. Again, thank you. Can you come and have a photo, all of us? You take a photo for us. Yeah, we give it to. He will do it. He will do it. If you want some photo, you can give your phone to you. What's your first name again? Clément. To Clément, and he will take a picture for you.